Welcome back. We're here with the Clinical and Translational Science Collaborative of Northern Ohio and our Dissemination Implementation Science Symposium. And I am with my colleague, Valerie Chip, who will be here moderating our next session. And our next session are case presentations of some of our emerging scientists who are doing implementation science work. And so they will introduce themselves. And our first speaker is Dr. Sarah Ronis. She's the director for the Center for Child Health and Policy at Rainbow Babies and Children's Hospitals at University Hospitals. So Dr. Ronis, we're very excited.
Thank you very much. I'm really grateful for the opportunity to present really what's a work in progress at the moment. I'm just going to go ahead and get my slides going. And while I'm doing that, I will say that I am a academic general pediatrician, practice in peds primary care at the UH Rainbow Center for Women and Children in Midtown Cleveland, where we serve a population that is largely more than 85% insured by Medicaid and residing in among our more impoverished neighborhoods in the city. So speaking of asthma being a problem, whether or not you have research funding, I'm going to share with you some preliminary work that we're doing on a CTSC funded project to address asthma in school-aged children. We are specifically funded under Module E by the CTSC of Northern Ohio, and this funding mechanism was to promote health equity and reduce health disparities in chronic illness through the use of technology, and with a particular call to integrate community and stakeholder partners throughout the research process. We focus on asthma because it is a top health concern for families in our community. We live in the asthma belt with greater than twice the rate of asthma at every age, with greater disparities in both severity and outcome by race and socioeconomic status. For school-aged children with asthma, chronic school absenteeism, which is defined as more than 10% of eligible days missed, is a key marker for poor asthma control. Kids' jobs are going to go to school, learn both educationally as well as social emotionally, and if they're not in school and they're not getting those opportunities, has long-term impacts on their function as adults and ability to contribute to society in the long term. And because kids spend far more time theoretically in school than they do with us in our offices, schools have a really important role in asthma control. The overarching goal of the whole project is to identify and test community-endorsed strategies to optimize school attendance, really taking a design for dissemination approach. The first aim to really understand context, historical context, by defining sociological factors associated with chronic school absenteeism. To, through qualitative work, understand past and current school experience with elements of the American Lung Association Asthma Friendly Schools Toolkit, which I'll mention in a few slides. And then to put that information together, leveraging participatory group model building strategies to identify and prioritize candidate strategies for action. And then the most exciting and terrifying part of this project is we have funding for the back half of the funding period to pilot some of those identified action strategies and generate preliminary data regarding effectiveness and considerations for wider implementation. We have a really wonderful partnership team, key personnel from UH Rainbow, Metro Better Health Partnership, the Mandel School of Applied Social Sciences Center on Poverty, and the Center for Community Health Integration at CASE, and community advisors from Cleveland Metropolitan School District, or CMSD, which is the largest district in our county, as well as Cleveland Heights University Heights, Cuyahoga County through Invest in Children, School of Nursing, and really importantly, parents. We've organized this work leveraging the Anderson in a Day framework for health services. Our key outcome measure, as I mentioned, is school absenteeism. And we are measuring that quantitatively using school records that are housed in the child data system over at the Center on Poverty, integrating those with UH Medicaid claims to identify children with and without asthma based on diagnosis codes and prescriptions, both prescribed and filled. For that first kind of historical context quantitative aim, we started out with 250,000 Medicaid claims. When we narrowed down to our inclusion criteria of children 6 to 12 during the study period in Cuyahoga County, had about 65,000 children, of whom more than 60% we were able to match into child, and of whom 25,000 we had school records for at least one academic year during the study period. And of that set of 25,000, nearly 5,000 children met our criteria for asthma. This slide shows prevalence of what we would call adequate school attendance. So these are students with less than 10% days missed in the academic year. The orange line are our students in our data set without asthma. The blue line are those with. And so as we expected in those pre-pandemic years, we saw poorer attendance amongst our students with asthma. Interestingly, and kind of as we knew from popular media and other sources, a steep drop-off post-pandemic, but unlike national data, we saw those drop-offs continue into the 2021 academic year, with those disparities between students with and without asthma emerging. Among our kids with asthma met our age criteria, the majority, as expected, were male, Black, and non-Hispanic. We looked at univariate associations with school absenteeism. We found that students residing in census tracts with lower health and educational opportunity had greater chronic absenteeism. Students with comorbid mental health conditions, so ADHD or anxiety or depression, had greater rates of chronic school absenteeism. Our students with chronic school absenteeism more often received public assistance as young children, but did so for shorter periods of time than peers who were not chronically absent. We saw lower rates of preventive care among our kids with chronic absenteeism, which would have been protective. And when we put these all together in multivariable models, some of those key associations persisted. So again, higher health and education opportunity in terms of residential location was protective against chronic absenteeism. Emotional, mental health, behavioral health concerns, increased chronic school absenteeism in the multivariable model, and children with adequate asthma medication ratios, so receiving filling as many controller inhalers as they did beta agonist or rescue inhalers or greater, protected against chronic absenteeism. So kind of cueing to some health system-based actions that could better support students with asthma in achieving those functions. The Asthma Friendly Schools Toolkit was actually developed about 20 years ago. CMSD was one of the original pilot sites, but as you can imagine, in 20 years, it's been a whole lot of change in the district and in the support. And that district alone has more than 100 sites with scholars. Focusing on the strategy one of that toolkit around maximizing school health services, our quantitative data is pointing us towards that first strategy, in particular facilitating linkages with medical home and making sure that students have connection to medical providers and that school sites have access to a consulting physician. In terms of understanding current state, we are in the middle of our educator interviews right now. But what we've learned thus far is there are very few sites with on-site school-based health centers. There's only one in the region that serves elementary age students, and none are affiliated with UH Rainbow. Parents were very consistent in sharing with us the need to increase the timeliness of response to asthma concerns and the range of adults in a school building beyond the school nurse prepared to respond. As I said, we're in the middle of our educator interviews, but hearing pretty consistently need for greater communication from and support to school nurses and personnel by healthcare providers. And then from our healthcare team members that we've interviewed, not surprisingly, but to this group, it's all about the details and strategies for how you're going to implement those communication and other educational support strategies. So we are getting ready to transition into group model building workshops facilitated by Dr. Peter Hoffman, who I think you're going to hear from later today. Those will generate for us prioritized action ideas and the ability to simulate and hopefully forecast the impact of those action ideas if implemented, that we'll then be able to compare our real world data against. We'll be developing those intervention materials this winter and spring, recruiting sites, and then using the academic year 25-26 to pilot test in up to 3 buildings. So thank you very much for the opportunity to share this work in progress, and I look forward to the conversation.
And now we'll hear from Dr. Xiao Li.
Okay, thank you. I'm so happy to have this opportunity to talk about our work on using wearable technologies for disease detection and management. Just brief introduction of myself. I'm assistant professor at Case Western Reserve University. I'm also holding consultant staff position at Cleveland Clinic and a non-compensation worker at Metro Health. I did my bachelor at McMaster University, PhD in Toronto, and postdoc at Stanford University with Michael Snyder. I joined the Case at 2019, luckily recruited a group of talented people contributed significantly to the projects I will describe to you later. So we know the technology and the market of wearables grows extremely fast recently. It was a report that more than 25% of Americans use wearables. Those devices continuously monitoring important physiological parameters such as heart rate, skin temperature, glucose level. So a typical wearable device like Fitbit or Apple can collect more than 1 million data per day per person. So the current challenge is how to actually translate this deep physiological data to interpretable health-related messages. For the past decade, I've been working on developing big data collection and analysis tools to help address this issue. Back to 2017, I actually, still a postdoc at Stanford, led a team to perform the first systematic study to use commercial wearable device for early detection of disease, such as Lyme disease and viral infection. Due to the time limitation, I'm just going through the key results. So we have monitored one person over 600 days. And here's a scatter plot showing at the daily level how the wearable data suggests this person's health status. So each dot here is a day. Lots of dots are collected together at 0, meaning this person is completely normal in terms of wearable measured heart rate and skin temperature compared to his own baseline. But we also interestingly identified a few outlier days. When we overlay this data to this person's electronic health record and the clinical panels, we found that this outlier days actually perfectly aligned with the sick events this person experienced with this 2-year period, including a viral infection, Lyme disease, and 2 high CRP events, indicating their systematic level information going on. So we were very excited by this observation. Paper was published in PLOS Biology as a cover article, received quite a bit attention from the news as well. So based on these results, we developed an algorithm called change of heart, which aims to identify abnormal heart rate pattern to flag disease at early stage. We tested on this person and of course another cohort of population. In the pandemic, we repurposed this algorithm, try to use this for COVID-19 infection detection. So as a summary, we successfully use a machine learning algorithm combined to analyze the wearable collected data and being able to flag a COVID-19 4 days ahead of symptom onset day and 7 days ahead of diagnosis day. Currently, we are further working on this direction. We got R1 supporting to using wearable technology and machine learning for detecting post-operative complication. This is a work collaborated with Mass Journal. So in the pilot phase, we successfully recruited 129 patients, either went through thoracic or cardiac operation. And for the computational algorithm, we successfully using it to detecting post-operative events with sensitivity of 0.81, specificity of 0.75, and a median of 2 days prior to the onset of symptoms. So, okay. So, so the first section, I'm briefly introducing you our work in using wearable device and technologies for disease detection at early stage. Due to time limitation, please refer to those papers I'm listing here if you get interested. We are also still actively recruiting patients to 3 IRB-supported approved studies. This QR code, you can use it to get more information or even join the study. So I actually want to share another thing is like through the work of these projects, I actually slowly recognize that, it's of course critical to develop robust big data and analysis tools for this project, but this is actually not enough by itself. The real world implementation is just as important as the analytical part of the site to make sure this project can be implemented successfully. So in the next part of my talk, I'm going to share with you our 2 recent initiatives we made on these directions with a focus on recruitment and adherence. So we were very fortunate to receive CTSC funding to support our COVID work, and which allowed us to actually explore different recruitment approaches and their impact on the study. So briefly, we looked at the 3 different approaches: online ads, such as using Google Ads or Facebook ads. We also have clinical introduction method with a collaboration with Dr. Wilson Tang at the Cleveland Clinic. Third, we also have active recruitment, which is basically through friends' recommendation or participants actively seek for information about the study. Regardless of the recruitment strategy, all participants were consented through REDCap, and the exact same data collection and analytical tools were applied for all those the data of all those patients. So we first compared the impression to consent pipeline to understand how many of the impression we actually required to actually get 1 person consent to the study. So it's harder to get the accurate number for the active approach for the impression. So we focus on the clinical introduction approach and online ads. It is clearly that clinical introduction actually have a much smaller impression to event ratio compared to the online ad approach. This may suggest that the participants actually have a much higher trust level with the healthcare institution, or alternatively, also we are actually through the online ads competing with a much larger marketing budget targeting the same population. We also compared the patient demographics. So through these 3 methods, we found that the online ads actually recruit the most diverse population to the study. Third, we compared patient adherence. As you can see here through these 2 bar plots, the active approach actually yielding most data, like the patient recruits through either friends' recommendation or actively looking for study information. They actually provide more data, both wearable and survey-based. So, of course, we still needed to perform many more experiments and analysis to get this into deeper knowledge. But I'm very fascinating to actually realize that even just like using a different recruitment methods, we can actually see different results through multiple stages of a study. And we are very encouraged that, those actively recruited patients, they actually gave more data, yielding a higher study adherence, suggesting that positive impact from a peer influence or a more high-touch approach probably is helpful in terms of engaging patient participants. So besides this, we're also actively working on approaches try to help increase adherence for the patients recruited through other approaches. So this is our work on the surgical cohort that I mentioned earlier. So we recently implemented a new protocol that we will actually perform data quality control on data on a weekly basis. And then we'll have the clinical team to call the patient for a friendly reminder. Just these steps, we've been able to largely increase the study adherence. Of course, we still started, and we are keep working on this and try to get, but I think we are at the right direction. So overall, I believe it is very important to consider both analytical and the implementation aspect for when running digital health projects. In the future, we will actually try to improve both aspects and try to make our current project and next project successful. With all this, I'd like to thank everyone in my lab for the fantastic work, and my close collaborators, Dr. Xiao Li, Dr. David Campbell, Dr. Wilson Tang, Dr. Jeff Young, and Michael Snyder, and all the funding sources supporting this study. Thank you for your attention.
Thank you very much. Those are both excellent examples of team science, interdisciplinarity, and engaging with different and diverse stakeholders to achieve your project goals. We have time for one question in this session, and I'm wondering if you could each comment on either how implementation science has enhanced your project, or if you could please comment on how you have taken or perhaps are planning to take issues of equity into consideration in your project implementation. And we'll start with Dr. Ronis.
So in terms of implementation science, I think especially the tools and practices, I have found leveraging those tools and frameworks incredibly valuable in assuring that every member of the project team and our advisory group are ultimately on the same page, because we're all bringing different lenses, different perspectives, different motivations to the work. And having a shared understanding of those frameworks have been really helpful, particularly when we're navigating, aligning kind of various motivations and timelines for the work to keep it moving forward.
Great, thank you. And Dr. Li, if you have any comments either on how implementation science has enhanced your project or how you've taken issues of equity into consideration.
Definitely. As I mentioned, it's for me, I started with the technical side, and slowly I realized it's very important to actually have focused on the implementary science of the projects as well. So when running the wearable tech studies, we will always worry about whether people can adhere to the study. We were happy that we're developing a very remote and automatic platforms so that we can get all the data from patient in a scalable, interoperable, and a secure manner. But on the other side, I think recently I realized the high touch part is also extremely important to ensure that we get a higher adherence from the patient. And it's good that it's a passive monitoring systems, but at the beginning, peer influence or like the interaction between the clinical team, research team, and the patients will largely help engaging the participants and getting the data running well and smoothly. And we also realize the important for the recruitment and pay attention to all aspects of the studies, steps of the steps, so that we can ensure this technology was tested on a diverse population, and so that the project can be later on benefit for the entire population.
Wonderful. Thank you so much, and thanks to both of you for sharing this really exciting, innovative work that you're doing. We are now going to transition to our next session of the morning, which will be our second keynote presentation.